Neurofibromatosis type 1 is the most common among the phacomatosis or neurocutaneous syndrome. It is named phacomatosis because initially what was studied was NF1 and tuberous sclerosis, in which tumors were seen in the eyes. It was also noted that this patient exhibit characteristic cutaneous manifestation aside from their CNS abnormality. So to remember NF type 1, that it's the most common among the neurocutaneous syndromes, you think about number 1, it's the most common. And to remember that it's chromosome 17, which is abnormal, you count the number of letters for NF, for neurofibromatosis, that's 17. So what is abnormal in neurofibromatosis? You have abnormal neurofibromin protein. This protein has a job to control or keep in check the RAS protein. And this RAS protein, when it's unchecked, it will lead to abnormal cell growth. So if you have abnormal chromosome coding region in chromosome 17, you'll have abnormal neurofibromin protein, which will then not inactivate the RAS protein. The RAS protein will become overly active and will lead to cell growth. The structures in which neurofibromin protein are found are the nerves, the oligodendrocytes, and the Schwann cells, and the neural crest derivatives. Schwann cells is from the neural crest. Melanocytes are also from the neural crest. So neurocutaneous means you have CNS abnormalities because you have abnormalities in the derivatives of the neuroectoderm. You have cutaneous manifestation because neuroectoderm comes from the ectoderm, and the ectoderm has a superficial part which gives rise to your skin and the dermal appendages. So these are the diagnostic criteria for diagnosing NF type 1. I'll put them in boxes. Okay. We need to fulfill at least 2 of these criteria. First is the cafe au lait spots. These are macules or flat lesions, flat pigmented lesions in the skin because of abnormal melanocytes. But these are benign. Next, you have neurofibromas. When you say neurofibroma, okay, what is seen in that mass is that you have abnormal Schwann cells, plus you also have abnormal stromal tissue, which includes fibroblasts. And this fibroblast gives rise to the name of the neurofibroma. If you form neurofibromas in the superficial nerves or in the subcutaneous nerves, you'll have these masses in the dermis. And you call this the dermal neurofibroma. If you have deep neurofibroma in the deeper locations in which they form along the nerve fascicles, just like this, it is called the plexiform neurofibroma. Histologically, this neurofibroma and plexiform neurofibroma are similar, but we just make the distinction because the plexiform neurofibroma have a tendency to develop into malignant peripheral nerve sheath tumors. Also, plexiform neurofibroma is pathognomonic for NF type 1. Okay, next criteria is that in NF type 1, patients are predisposed to develop an optic nerve or visual pathway glioma. Glioma, you have a tumor in the glial cell. Glial cell means a supporting cell, supports the neuron, and in this case, the optic nerve glioma is usually a low-grade astrocytoma. So here, you have abnormal enlargement of the optic nerve on both sides, making the optic nerve tortuous, and on contrast studies, diffusely enhancing. Covers the intraorbital, intracanavicular, and it has also an intracranial segment. You have to trace the more proximal pathway of the visual pathway because glioma may spread in that direction. So in this case, you have abnormal hyperintense signals, and this corresponds to the optic tract in this diagram. Other findings, another criteria is sphenoid wing dysplasia. So the sphenoid wing may be underdeveloped or be absent. In this case, portion of the greater wing is absent. That's why the volume of the orbit is increased. Another criteria is the presence of Lisch nodules or Irish Hamartomas. When you say hamartoma means you have abnormal cell proliferation in an area where that kind of cell is normally found. So, for example, we have here in the iris normally has melanocytes. But in this case, the melanocytes proliferated, giving rise to melanocytic hamartomas or the Lisch nodules. So these lesions are benign. Another criteria is since this disease is autosomal dominant, presence of a first degree relative with NF1 is also part of the criteria. So you just have to fulfill 2 of these criteria to make the diagnosis. Now, when we image the brain of patients with NF type 1, you can also see abnormalities, which are called foci of abnormal signal intensity. Let's take a look at that. Foci of abnormal intensity. So let's take a look first at T1. So this one's a T1 sequence. It is not unenhanced, but you can see here abnormal T1 hyperintensity. The hypothesis on why this happens, on why this abnormal T1 hyperintensity is formed, is that can be due to abnormal myelin deposition. And myelin has high lipid content, that's why it's T1 bright. Another is that it could be from abnormal melanocyte accumulation. And melanin is T1 bright. So what is common about this one in the possible reason for this T1 hyperintensity is that Schwann cells and melanocytes are formed both from the neural crest cells. So that's why this is a theory for having these T1 hyperintense signals. You can also have abnormal signals on T2, which can involve gray matter, white matter. In this example, we have T2 hyperintense signals in the basal ganglia. We also have abnormal hyperintense signals in the dentate nuclei, in the middle cerebellar peduncle. We have it in the pons. And this T2 hyperintense signals can be due to several things, and their hypothesis is that it can be due to abnormal myelin vacuolization, meaning the myelin becomes degenerated, and instead of the tight myelin spirals, you have the myelin which is more loosely packed. That's why you have more fluid in between. So that's one theory. You can have myelin vacuolization, you can have gliosis in that area. Also here, you can see that there's abnormal hyperintense signal in the thalamus, abnormal thickening of the hypothalamus. So these are the abnormal foci of abnormal signal intensity. Another entity that can be seen or that we can label these entities are hamartomas. And for us to say that an abnormal signal is a hamartoma, there should be little or no edema surrounding it. There must be little or no mass effect. And there should no be evidence for hemorrhage there. So that's the end.